This is LiveWell Talk on Inspire for obstructive sleep apnea. I'm Dr. Dustin Arnold, Chief Medical Officer at Union Point Health, St. Luke's Hospital. Obstructive sleep apnea is a common and potentially serious disorder that causes the person's breathing to repeatedly stop and start during sleep. Joining me today to discuss Inspire, an implantable device for obstructive sleep apnea, which is now available at St. Luke's, is Dr. Thomas Heineman, otolaryngologist at Physicians Clinic of Iowa, ear, nose, and throat. Welcome, Tom.
Thank you so much for having me, Dr. Arnold.
And of note, he just finished one of these procedures today. We were just talking about it. So,
Yep.
you know, I think that sleep apnea is underappreciated. I can remember early in my career, the late 90s, where you didn't really screen for it. You know, you did,
Yeah.
You know, or you didn't, you might have screened for it and treated it, but you didn't think about the other problems it called other than daytime somnolence.
Yep.
You know, and I'll never forget the time I did a cardioversion, and then respiratory therapist and I were sitting there, and the guy was a big guy, and he kind of had some sonorous respirations and went back in AFib, and I was like, oh, sleep apnea must be bad for your heart. You know, and so then we put it together. So, you know, now I think we do a good job of thinking about it with strokes and heart attacks, et cetera. But as people that will probably listen to this podcast, there are some people that they don't tolerate the CPAP machine, or maximized CPAP still doesn't solve the problem. So tell us what this Inspire sounds really interesting, and just walk us through what it actually is.
Sure. You know, I have this conversation, as just to back up a little bit, just about obstructive sleep apnea. You know, I have it every day with multiple patients. And, you know, the example that I kind of like to use in terms of sleep apnea is that it's similar to smoking in the sense that it's chronic damage over decades.
Yeah.
And it just increases the wear and tear on your heart, on your brain. And, you know, it's not necessarily something that you feel that incremental change every day, but that incremental damage over decades definitely leads to, as you alluded to heart arrhythmias, to stroke, to coronary artery disease, to many other things, you know, not just the, oh, I'm tired type of thing. So I think that certainly there's much more awareness now, but no, it's a very, very important health issue. And, you know, I'm certainly advocating for CPAP. CPAP is wonderful in terms of being the gold standard on how we treat obstructive sleep apnea. However, as you also alluded to, there is a population that just doesn't get benefit from sleep apnea. And that can be from a wide range of things. Some people are claustrophobic. They don't like things on their face. Some people just are really active when they sleep, and they rip off the mask, they get tangled in the hose. And, you know, despite trying multiple masks and multiple different, you know, types of equipment, they just can't seem to make it work. Other people, and, you know, we can get into this a little bit later, their anatomy actually just doesn't allow it to work. And what I mean by that is that there are certain ways that the throat collapses that we're only now starting to discover through a procedure called a sleep airway exam, where we actually put the patient to sleep, similar to a colonoscopy or an upper endoscopy. And they're still breathing on their own. And we try to replicate kind of a sleeping arrangement where we turn the lights off, they kind of start snoring. And the way that their throat collapses, sometimes there's a small kind of flap in the back of the throat called the epiglottis. And sometimes the collapse is actually at the level of the epiglottis, which, if you actually think about CPAP blowing air in, it actually causes it to close even more. So there are people who, despite all of these things, just say, you know, I use CPAP and I just don't feel rested. It just doesn't work for me. And that's, you know, probably because there's some anatomical factors
Right.
that are playing into why the CPAP doesn't work for them as well. So, you know, that's a very broad topic about, you know, CPAP, but, you know, to get in a little bit more narrow in terms of Inspire itself, it was initially approved by the FDA in 2014, and I've been implanting since 2016. And it's a revolutionary technology. You know, there are very few things in medicine that I think have just, you know, aren't adaptation from other, you know, other things or evolution of other things. I mean, this kind of came out of left field in terms of how we think about sleep apnea, how we treat sleep apnea, because what it does is it actually uses the body's own muscles to stimulate the airway to open. So if you can think about CPAP, what that does is, again, if we assume that the airway is closing up, when you breathe, the throat collapses. What CPAP does is it blows air in there and pushes everything open from the inside. Whereas the way Inspire works is actually we're triggering the muscles to fire, to strengthen the throat and open the throat using the body's own anatomy, its own muscles. And that's really where the Inspire differs from CPAP. It's accomplishing the same thing, just through a totally separate mechanism.
That is interesting. And as you're talking here, I was thinking about how it's interesting that treatment for sleep apnea it's been a pendulum, because it used to be that sleep apnea, if you needed to be treated, you went to the ENT guy and he did the
UP3.
Yeah, UP3, and it was a huge operation, is like is tonsillectomy on steroids, and then it went to the neurologist and the sleep. Then it went to pulmonology, and it's kind of landed on the neurologist, and now it's coming back to ENT. I find that's the circle of life symbol.
Yeah.
But that's interesting. So take us a little bit more through how it works.
Sure.
I think this is fascinating.
So there's a nerve under the jaw, which is called the hypoglossal nerve, which is actually a nerve that controls the motion of the tongue. And within that nerve, and without getting too into the weeds, within that nerve, there are branches that go to muscles that push the tongue forward, and there are branches of the nerve that go to muscles that pull the tongue back. We want to pull the tongue back when we swallow, but we want to push the tongue forward when we breathe, because otherwise, again, that tongue is going to fall back in the throat. And what they found with some kind of early anatomy study is that we can actually isolate the branches of the nerve that push the tongue forward. And if we stimulate those preferentially, we can actually move the tongue forward. I mean, like a little remote, you turn it on, the tongue goes forward. And so that's the basis, the kind of the underpinnings of this technology. So, what we do is we put a small stimulating cuff around a portion of the hypoglossal nerve, and then there's a small pacemaking device which sits in the upper chest over the pectoralis major muscle, just the pec on the chest, and then there's a second wire which goes in between a rib space, and the reason we have that is that senses when you breathe. So the sensing wire is basically syncing the stimulation to your breath. We don't want the stimulation to be active all the time, all night long. We want it to only be active when you're taking a breath, because that's when that tongue is collapsing in. So, a patient who has Inspire, what they typically do is there's a little remote. They go to bed, just like anyone else. They don't have any other equipment. They have a small remote that they just hold over their chest. They turn it on. There's a delay, approximately 30 to 45 minutes. You can set that whatever you like, just enough time for you to fall asleep. And then the stimulator starts slowly and gradually works up, providing you with enough stimulation that you're not awoken by the stimulation. It's not painful, but it starts basically pulling the tongue forward every breath you take. And then when you wake up, you turn it off, and you go about your day. And today is actually a very interesting day to talk on this podcast specifically. So we had our first 3-month follow-up. So 3 months ago, we started doing them. And then 3 months later, you get a sleep study where you go into the sleep lab, similar to anyone who's had a sleep study. And what we can do is we can actually turn on the device while you're asleep and turn it off while you're asleep. And we can watch what your actual sleep severity is. So we call that the apnea hypopnea index, or the AHI. That's how we diagnose sleep apnea. And this particular patient, who was our first patient, he had an AHI, I believe, in the 40s. So that's someone who's stopping breathing 40 times an hour, or almost every minute and 10 seconds or so. And when we turned it on, his basically sleep number, AHI, was less than 5. And then we turn it off and it goes back to 40. We turn it on and it goes down to 5. And it's really remarkable that we can see that in real time, real patient, and you have that control all night long. You turn it on, you see what it is. You turn it off, you see what it is. And it's just a really amazing technology.
40 is severe.
Yep.
And that patient's going to be symptomatic somehow.
Yep.
the tough ones are the ones that are like 15 to 17.
Yep.
They snore, spouse complains, but they don't feel that bad. And so it's like you said, it's like smoking. They can't see the damage, so it's hard to get them to do it. But going down to 5, I mean, 5's a normal variant of some people. I mean, that's
exactly. So,
So,
and that was just today, and that's not an outlier. That's typically what we expect. We screen heavily, so there are a lot of people who might be interested in the device. There is a certain criteria that you have to qualify for because it's more invasive than a CPAP, and we want to select patients who are going to benefit from it because it's more invasive, and to do that you have to be under a certain weight. So typically a BMI less than 35. You have to have severe enough sleep apnea, which you totally alluded to. We're not typically implanting people who have, a number of 5 or 6. We're implanting people that have to be above 15. So 15 is the cutoff from mild to severe, and above 30 is severe. So basically mild or severe are technically candidates. And then you have to have this airway, a sleep airway exam. Because what we found in the few thousand of these that have been implanted is that, and with sleep, there's still a lot we don't know. We're progressing slowly, but there's still a lot we don't know. And there's a certain collapse pattern in the throat. You can collapse kind of from front to back. You can collapse from side to side. You can collapse at the top near the palate. You can collapse all the way down at the bottom near the epiglottis, which I had talked about. And there's a collapse pattern that is like a funnel where everything collapses, but kind of circumferentially, and those patients do not benefit from the Inspire device. And we still don't know why, but it's just that their musculature, the nerves that control their throat, we can't kind of like take control and open it up with the nerves because again, it's something we don't understand. But by doing the airway exam, we can screen those patients before they get implanted and don't succeed with the device. So all of these steps is to make sure that the patients that we are implanting are ones that are going to benefit from it. And we expect so greater than 75% decrease in their AHI in over 90% of patients. That's what we expect. That's what we hope for. Greater than 95% of people stop snoring. I mean, by selecting the correct patient, it's really, really a very transformative piece of equipment for the patients.
So, a couple questions. One is, because here's what people are going to think, and can you use a microwave if you have one?
Yep. And the reason it's similar hardware to a pacemaker, which does have those types of restrictions, a cardiac pacemaker, heart pacemaker, but this is only on when you're asleep. So during the day, it's totally off. So it's basically in an off mode. So there's no.
Are you able to talk, or do you have to turn it off to talk?
You would turn it off because again, it's not painful, but your tongue, every breath you take, your tongue is basically comes forward in your mouth, which we turn it on in awake patients during the activation right after a month after the implant, and they're a little bit surprised. It feels a little strange, but no, yeah, you would just turn it off. You wouldn't want to talk with it.
Okay. All right. Well, that was a fair question.
Exactly. No,
what are some other candidates? They can't be morbidly obese. They have to be BMI 35, which that is moderately obese. Is there a certain age they have to be? Is there a certain age where you say, okay, this is a mature problem, we can fix this?
Yep. Over 18 is the current FDA indication. There are some studies looking at younger than 18, specifically in the Down syndrome population. That's not it. That's still off-label, but that indication might be coming because obviously there's a lot of sleep apnea in that population. But no, those are really the only kind of candidate metrics that we look at. But it's covered by pretty much every insurance if we meet those metrics. So they have based on the FDA indications, they have a checkbox that list of things we have to go through of all these things, and if it's met, then typically it's approved without an issue.
So you would recommend that the patient that has a sleep apnea and is not doing well should perhaps talk to their primary care physician about getting a referral to over to see you.
Exactly. And, sleep is, as you, again, mentioned in the beginning, a lot of people touch sleep. So, pulmonology, primary care, sleep, neurology, and ENT. And, sometimes the point person is the sleep team, where they're the ones who are, trying different masks, trying different CPAP outfits. But certainly, the absolute place to start is to make sure you have a sleep study within 2 years. If you come to see me, again, I'm happy to see anybody in consultation for Inspire. But if the sleep study isn't within 2 years, that's, the whole point of the visit would be just, okay, we can talk about it, but we can't really move forward unless you do have an up to date sleep study. But after that, we can certainly chat about, if it would be right for you, or if you think, you just want to hear some more about it. There's a ton of information online. The Inspire company has a website, inspiresleep.com, and they have just an enormous amount of resources, videos, educational materials. So, feel free to check that out as well, just to see if you want to, learn more about the device.
Well, Dr. Heineman, that was great information. I think it's really exciting. I can remember about 1996, there was kind of an article where they were mentioning that we could use pacing for gastroparesis with the diabetic, kind of to empty the stomach, and they also say it's speculated that perhaps someday they could use it for sleep apnea. So that's, I distinctly remember reading that article.
And I think now they're doing neuromodulation as well for CHF. Obviously, they use it for epilepsy. Those are, on the vagus nerve, but it's very similar devices, very similar principles. I mean, this is kind of a new wave in trying to use the body's own nervous system to, to tweak it, not with a drug, but with with the stimulation.
I don't know. I can't remember the name of the drug, but it's basically a daytime stimulant. They have, I don't think it's Provigil, but it's similar. Came out on the market. I saw the TV ad. I'm like, just another drug to throw at people. So I think this is really exciting. Mm-hmm. And I'm glad you're doing it. Thanks again for stopping by, Dr. Thomas Heineman, otolaryngologist at Physicians Clinic of Iowa, ear, nose, and throat.
Thank you for listening to LiveWell Talk On. If you enjoyed this episode, don't forget to subscribe. And if you want to spread the word, please give us a 5-star review and tell your family, friends, neighbors, strangers about our podcast. We're available on Apple Podcasts, Spotify, Pandora, or wherever you get your podcast. Until next time, be well.